Welcome all of you to this live program at Athletic Principles. Today, our guest of honor is Professor Shital Parikh from Cincinnati, United States. Professor Parikh is co-director of Orthopedic Sports Center at the Cincinnati Children's Hospital in the United States. He specializes in pediatric sports medicine with clinical research interests focused on patellar instability, pediatric ACL injuries, arthroscopic treatment of joint instability, and pediatric trauma. After completion of his orthopedic residency from India, completed fellowships in joint reconstruction at the Hospital for Joint Diseases in New York, a pediatric orthopedic fellowship at the Cincinnati Children's, trauma fellowship at Sunnybrook, Toronto, a sports medicine fellowship at Cincinnati with Professor Frank Noyes. He has published several scientific articles in peer-reviewed journals and has been the editor of 2 books, one on pediatric ACL and the other one on patellar instability. He was awarded the ISACOS Patellofemoral Traveling Fellowship in 2014. If you notice, Professor Parikh has delivered a lecture on a channel that's already reached a huge audience. And today is my great honor to bring back Professor Shital Parikh for this wonderful live program. Over to Shital.
Thank you, Hitesh, for that kind introduction. Good morning, good evening, depending on where you are. I'm really happy and passionate about this topic on patellar instability. So we're going to talk about different instability patterns in adolescents and children, focus a little bit on MPFL reconstruction, since that has become one of the standard treatment for patellar instability. As far as the talk is concerned, we're going to talk about types of instability, how to evaluate the risk factors, the approach to management, and then talk about MPFL reconstruction, and then about quadriceps flaccid, which is also commonly done in children for several complex patterns of instability. So we start with types of instability. Now, before we look at the typical lateral patellar instability, it is better to just know different types of instability that are out there. So if we look at this picture here, what you note is that the screw is on the lateral side. This is not an MPFL reconstruction. It's actually a lateral patellofemoral ligament reconstruction, which is done for medial patellar instability. And medial patellar instability is almost always iatrogenic. Recently, we polled the IPSG members who are experienced patellofemoral surgeons, and we could find only 4 cases of non-iatrogenic medial patellar instability. So after someone has an extended or unindicated lateral release, patients can have medial instability. It is difficult to diagnose because they don't have frank dislocation, and one has to be suspicious with a history of lateral release. If the patient continues to have ongoing symptoms, then one has to be suspicious, and the treatment is a lateral patellofemoral ligament reconstruction. But we are not going to talk about it in this talk. The next type of instability is vertical instability. Now, fortunately, this is not seen in the adolescent patients. It's typically seen in older patients, and it's related to the osteophyte set. An osteophyte from the top of the patella can engage the notch, causing the patella to dislocate within the notch, or the inferior osteophyte can catch on the top of the trochlea and cause a vertical instability, and we would not discuss this as well. The other types is multidirectional instability. As you can see in this example, the patient had both medial and lateral instability. This is typically seen in patients who have significant hyperlaxity, like Ehlers-Danlos syndrome, or patients who had previous lateral release and they already had lateral instability and now have developed medial instability. Then it would be multidirectional, but we would not talk about that as well. I have seen a rotational instability, which is a horizontal instability where the patella everts and dislocates in an axial plane, and is typically seen after quadriceps flaccid or big releases. And if you cannot tether the patella or keep it down, then it can evert and rotate out. And we would keep that instability out of this talk as well. So we'll just focus on the lateral instability, because 99% of the time when the patient comes in with instability, it is a lateral sided instability. Now, the previous classification of the terms that have been used for patellar instability, like acute and chronic and habitual and congenital, these are not true terms that should be used during research or for comparing patients. For example, chronic dislocation, what does that mean? Does that mean that the patella has dislocated for a long time and has never come back in the groove, or does it mean recurrent dislocation? Same with acute. You can have an acute dislocation if it just happens, if you just look at the time. But what if it's the first time dislocation? What if it's the 10th dislocation? The treatment is different. So an acute patellar dislocation can just tell you a little bit about what happened recently, but cannot give you a little bit, more information. That means it kind of guide treatment. So these terms shouldn't be used routinely. Instead, the terms that should be used is a first-time dislocation or a recurrent dislocation if there are two or more dislocations. And a dislocatable patella, which is typically habitual dislocation where the patella dislocates with every cycle of flexion extension, or a dislocated patella where the patella remains outside of the trochlea for the entire range of motion. And within this types of instability, you can further subdivide them. This is not for memorization. This is mainly to be more comprehensive of types of instability that can happen. We'll just see a few examples. The complexity of dislocation and the treatment increases as you go from type 1 to type 4. The type 1 is the first dislocation. 15 or 20% of the time the patient presents with a dislocation, but a lot of time you just extend the knee, the patella reduces, and that's how the patient presents, is a patellar dislocation that reduced on its own. It can be with or without osteochondral fracture, and it is important to differentiate that because the treatment is different. About 25% of patients can have an osteochondral fracture after a first-time dislocation. When we talk about osteochondral fracture, we are talking about real fractures more than 15 to 20 millimeters in dimension, and that would need fixation. Type 2 instability is the one which is recurrent dislocation to two or more patellar dislocations, and the cornerstone for treatment here is MPFL reconstruction, and additional procedures may be required based on anatomic factors. These patients can have hyperlaxity, which is typically determined by a Beighton score, and anything more than 5 out of 9 on a score represents hyperlaxity. Type 2A is that the patient has subluxation, so may have had one dislocation, but then remains symptomatic and has subluxation episodes. And these can be disabling. The patient can have pain, can have apprehension, can lose function, can have swelling or partial giving way episodes. And if the patient has exhausted conservative treatment, which includes bracing and physical therapy, then an MPFL reconstruction can help. Type 3 is a patella that dislocates with every cycle of flexion and extension. So here you can see that in extension, the patella comes back, but as soon as we flex, the patella dislocates. Now, one thing we have to differentiate is that whenever there is a tracking issue of the patella, before doing an MPFL reconstruction, the tracking has to be restored. If we just do an MPFL reconstruction for someone who has a habitual dislocation, the graft is going to stretch out. So the MPFL is used as a check rein or to keep patella on a track, but it is not used to pull the patella onto the trochlea. So for a habitual dislocation like this, the cornerstone of treatment is based on quadriceps plasty. That is where you reorient the quadriceps tendon, and that would help in maintaining the tracking. And then you may or may not have to do an MPFL reconstruction. This is a habitual dislocation of the patient in flexion. As soon as you flex the knee, the patella dislocates. You can also have it on both sides, and that's very common. And there is a lot of underlying dysplasia. Now, you can also have habitual dislocation and extension, as you can see here. So how do you differentiate habitual dislocation and extension from an exaggerated J sign? Because J sign is also present when you extend the knee. So habitual dislocation and extension, the patella does not come back into the groove in the first 30 degrees, that is from 0 to 30 degrees, whereas a J sign, the patella would come back as soon as you start to flex. In habitual dislocation, the patella tends to remain out of the groove till you flex deep or more than 30 degrees. These are also frequently bilateral. You need to evaluate for the underlying dysplasia. Another group is voluntary dislocation, where the patient can learn to selectively contract their muscle and dislocate the patella without moving the knee. And these are typically treated with physical therapy, just like habitual dislocation of a shoulder. You can get bilateral voluntary dislocation. This is a slide from one of my friends, Dr. Jyotish Patel in Ahmedabad, and he sent me this patient with bilateral voluntary dislocation of the patella. Type 4 is a permanent dislocation where the patella is outside of the trochlear groove. They may be reducible or irreducible, and a lot of times they may be associated with syndromes. This patients typically require quadriceps realignment or quadriceps flaccity. This is another example of a fixed dislocation. This patient had a distal femur fracture, had dislocated the patella, and patient was casted for treatment of femur fracture with a dislocated patella, and then ended up having a fixed dislocation. This is an example of a syndromic patient. Both the patella are well outside of the trochlea, but it's important to look at the nails. If the nails are dysplastic in a patient with bilateral dislocation of the patella, then it's a nail patella syndrome. There could be any of these syndromes besides nail patella. It could be Rubinstein-Taybi, Down syndrome, Kabuki, Morquio, and there are several others out there, and they can present with any of the patterns from 1 to 4. Not all permanent dislocations have an associated syndrome, and not all syndromic patients have to have a complex instability. They can still present with an episodic dislocation like type 1 or 2. This can run in families, as seen here. Both the mother and the daughter have dislocated patella. And if we divide how we are going to be treating this, then the typical episodic dislocation, which is first time or recurrent dislocation, happens during the adolescent age group. And the cornerstone of treatment is MPFL reconstruction. The more complex patterns of habitual dislocation or fixed dislocation, they typically happen in the first decade, and the cornerstone of treatment is quadriceps flaccity. How do we evaluate the risk factors? So we already talked about this hyperlaxity, which is measured on a Beighton index, which is 9 points, elbow hyperextension, thumb to forearm as seen here. And then if they can hyperextend their finger more than 90 degrees, knee hyperextension more than 10 degrees, and if they can touch the palm to the floor. If they're more than 5, then it is an indication of hyperlaxity. However, kids, typically younger kids, have a lot of joint laxity. So for them, the criteria is 6 out of 9 and not 5 out of 9. And the reason it's important is because we recently did a study where we were looking at the influence of hyperlaxity on the outcomes of doing an MPFL reconstruction. And what we found is that if the patients were able to touch the palm to the floor, for example, that indicates significant stretching of the hamstrings. And when we used their hamstring autograft to reconstruct the MPFL, their failure rate was much higher compared to patients who had an allograft reconstruction. So it is important to know how much hyperextension they have, and that may also help to dictate the graft. If you don't have access to allograft, then you should consider a semitendinosus graft instead of a gracidis in patients who are hyperlax. Apprehension sign is one of the most sensitive and specific sign for instability. As soon as you start pushing the patella out, the patient would not like it. The patient may show anxiety, pain, fear, and sometimes it will kick you. When we're looking at anatomic factors, these have been described a long time ago, 1994. So it's been about 30 years, and they are still valid. These are the factors that we look for. The major factors are trochlear dysplasia, patella alta, increased TTTG distance, and increased patellar tilt. And the minor factors are anteversion, external tibial torsion, recurvatum, and valgum. And the minor factors are mainly with the alignment of the leg, and the major factors are mainly around the knee joint. The merchant view is very important when you're looking at an X-ray. And even though it says that it's a 30-degree view, and a lot of people try to put the knee at 30 degrees to get a merchant view, actually the merchant view is done with the knee in 45 degrees. When we say 30 degrees, that's the angle of the X-ray tube to your body. That's 30 degrees. The knee is still flexed at 45. And how do you know that it's a good merchant view is that we are trying to assess the proximal part of the trochlea on the merchant view. And in the proximal part, the ratio of the lateral facet to the medial facet is 2:1. If that ratio is 1:1, that means you are pretty deep in the notch, and that's not a true merchant view, and you cannot get information about the shape of the trochlea when your knee is flexed more than that. We also need a perfect lateral view because lateral view is important for patellar height, trochlear dysplasia, and to just look at your overall sagittal plane alignment. So how do you get a perfect lateral view? So to get a perfect lateral view, you can put a sponge or a sandbag under the heel of the foot to level the leg, and the unaffected leg can be over and in front of your inwall leg. And then you tilt the gantry about 10 degrees, focusing on the knee, and you can get an almost perfect lateral view all the time. And how do you know that? Is that you have overlap of the posterior and the distal femoral condyles. The reason it is important because the classification of trochlear dysplasia, for example, is based on perfect lateral knee x-rays. And this is a classification. I won't go in details, but there are three things that define dysplasia. One is a crossing sign. Another one is a supratrochlear spur. And the third thing is a double contour sign. And the meaning of each of them can be represented in a model like this, that the double contour sign indicates a hypoplastic medial femoral condyle. The crossing sign indicates the flat trochlea, or at what level the trochlea gets flattened. And the supratrochlear spur is the offset of the trochlea from the anterior femur. So this has all three characteristics, which makes it a type D dysplasia. When you're measuring the patellar height, there are a lot of indices that are that can be used, including Insall-Salvati, modified Insall-Salvati, then Blackburn-Peel. But the one that is used more commonly for patellofemoral conditions is the Caton-Deschamps index, and that's the articular surface of the patella and the distance between the proximal superior aspect of the tibia to the lower end of the articular surface. MRI is really important, especially when the patient has an acute traumatic effusion. And when we looked at MRI in more than 100 patients, what we found that in a younger age group, majority of the time, you would have a patellar dislocation if the patient has an acute traumatic effusion. And in the older age group, majority of the time, it's an ACL tear. But patellar dislocation is not that uncommon. So at least 1/3, you can see an average, 1/3 of the patients with an acute traumatic effusion would have a patellar dislocation. The other way to differentiate the patellar dislocation from an ACL injury is a typical bruise pattern that you see with the patellar dislocation. It's on the medial facet of the patella and the lateral aspect of the anterior aspect of the lateral femoral condyle. And this is important because a lot of times when the patient presents with an acute traumatic effusion, it's difficult to evaluate the patient because of guarding, because of swelling, and an MRI can give you much more information. The TTTG distance is the distance between the tibial tubercle and the trochlear groove. It is calculated on two separate axial slices on MRI or CT scan. Normal values are 10 to 15 millimeters, and it has been reported that if it's more than 20, then it's abnormal. Now, a lot of studies have shown that in spite of an increased TTTG distance, because the measurement varies with the knee flexion as well as knee rotation. So in spite of having an increased TTTG, patients have done well just with an isolated MPFL reconstruction. So one has to be careful in evaluating these parameters and then making decision based off on that, because there is variation in how we calculate them and based on the position of the knee. For the studies, we look at CT rotational profile if there is a clinical indication. That means the patient is walking with the patella facing in and we think there is femoral anteversion, or if the patient has significant outgoing and has external tibial torsion, then getting a CT rotational profile with selective slices at the hip, knee, and ankle would help to calculate those rotations. And then every couple of months, we'll have a patient where we would have to do an osteotomy of the femur and the tibia to de-rotate them. The other things that we frequently get are full-length x-rays. Now, we are part of a bigger research group, and so all our patients with instability do get a full-length x-ray, but you can look at them clinically. If you think that they have genovalgum, then you can confirm it with a full-length x-ray. If the patient has a syndrome that has not been recognized, so if you see that the face is atypical or the amount of dysplasia is significant, short stature, or running in families, then having a genetic consultation would be helpful, because if we know the diagnosis, then we can know a lot of other things that goes with that syndrome. How about management of instability? So for a first-time dislocator without an effusion, typically the management is conservative. Now, there are different ways of managing it. We use an immobilizer initially for the first week or two, not more than that. And then we start physical therapy. If they do have an effusion, then the recommendation is to get an MRI to look for an osteochondral fracture. Because if there is a fracture and the size of the fracture or the fragment is more than 15 millimeters, then you may have to address it. Smaller fragments as cartilage flakes could be ignored, but bigger piece osteochondral fractures, they might have to be fixed or excised. And then there's an idea that if you're going to go in and treat one of these patients who has an osteochondral fracture, then might as well stabilize it at the same time. And this is what we do in our institution. So when you have someone with the first patellar dislocation, you have three choices. You can treat them non-operatively, you can do a medial-sided repair, or you can do MPFL reconstruction and address other factors if needed along with that surgery. So let us just look at the natural history. What if you don't do anything? What is going to happen? If we look at this study, 189 patients who were followed for 2 to 5 years, the females between 10 and 17 years of age had the highest rate of patellar dislocation, and there was a 17% rate of redislocation. So 17% is not bad. Then you want to treat all patients with first-time dislocation conservative if the rate of redislocation is only 17%. If the patient has second dislocation, the rate goes to 50%. That means for recurrent dislocation, the treatment should be some form of stabilization. Now, this is just one study. Let's look at an older study. His 1977 study, 48 patients with acute patellar dislocation who were treated conservative. If you divide them by age, then there was a 44% redislocation rate for patients who were less than 16 years of age. But then when you look at a little bit older cohort, not too much older, just 19 years, then none of the patients had a recurrent dislocation. You can see the discrepancy. It's 44% versus 0%. So just a few years can make a big difference. So when we are seeing patients, because we are Children's Hospital, we typically see patients before they're adults, are 18, 19 age range. Then you can see that most of our patients would come to surgery, whereas in someone who is in adult practice and their average age is, say, 25, then they might not need surgery. So younger the age, higher is the rate of redislocation. Now, that is only one way of looking at the natural history, is how many patients redislocate. But is that the entire scene? And it is not, because a lot of patients may not have dislocation again, but they might have other issues, the late problems, which is pain, subluxation, giving you episodes, fear of going back to sports. And that represents another 19% in this study. So if you combine this with the redislocation rate of 44%, then you're looking at almost a 65% failure rate. So compared to the first study that showed a 17% failure rate, that was just based on redislocations. If you combine other issues that the patient may have, now you see that the patients may be failing conservative treatment majority of the time, or 65% of the time. So what are the options for those who fail conservative treatment? You can do a repair, and we can compare the results of repair versus conservative treatment. Multiple studies have been done comparing non-operative treatment with medial repair. And then these are very high level of evidence. That means randomized studies, level 1 studies. And what all of these studies have shown is that there is no significant difference between non-op treatment or with a repair. What that means is either you don't do anything, or if you want to do something, repairing the stretched out tissues on the medial side is as good as not doing anything. So multiple studies have shown that. So my recommendation is not to attempt repair. Now, repair does give good results in selective patients, but it's very difficult to know which patient is going to do well. If a patient has normal underlying anatomy, had a true, contact injury with dislocation, and now has an osteochondral fracture, you go in and fix it, and you think, should I reconstruct the MPFL or should I repair it? Maybe repair might be a good, answer for that one particular patient. But to be honest, I find it very difficult to see patients without any underlying dysplasia. And since 2012, I've not done any repairs, and not in our institution. We don't do repairs anymore. We gave it up a long time ago, just because we had much higher failure rates, and MPFL reconstruction was a much better alternative. So it's not a good option, in my opinion. So MPFL reconstruction, when you compare that with the non-operative treatment, and this is a randomized study, then the MPFL reconstruction was much better than non-operative treatment, no recurrences, compared to 7 out of 20, which is almost 1/3 patients having recurrences. And even the patient-reported outcome scores were better in those who had MPFL reconstruction. How about a lateral release? So lateral release as an isolated procedure for instability is rare. It actually increases the lateral instability, not decrease it. And there are multiple studies that have shown that the lateral retinaculum provides restraint to lateral translation. And so if you take down the lateral release, you can make the patella unstable laterally as well as medially. So it's not a good surgery in isolation. So I would say my practice, we do lateral release in about 10 to 15% of the patients with MPFL reconstruction, but never as an isolated. The only time we are doing isolated lateral release is not for instability, it's for patellar hypercompression syndrome, where you have a tilt that is not correctable, you have cartilage issues on the lateral side, and the patient is having pain. Then you can do a lateral release for that sole indication. In the International Patellofemoral Study Group, even amongst the most experienced knee surgeons, isolated lateral release is rarely performed. Now, how about managing contributing factors? So first is the trochlea dysplasia. Normal trochlea has a sulcus or a groove, and then if you have a flat or a convex trochlea, then it's difficult for the patella to get balanced onto that convex patella, on the convex trochlea. So the treatment is trochleoplasty, where you have to go through intact cartilage, as shown here. This is a thick flapped trochleoplasty, which was popularized by the Lyon group, and this is the de jure type of trochleoplasty. The other type, which is more commonly done, is a thin flap trochleoplasty, which is also called the Bay-Reiter trochleoplasty. And there are several other variations of trochleoplasty. There is a variation where you can just take down the supratrochlear spur, which is a Peterson grooveplasty. There are other ways. There is a trochleoplasty that was described where you can do an osteotomy, and you can bring the trochlea at the level of the anterior femur. It's a wedge resection trochleoplasty that has been done in France. And then there were some older ways of elevating the lateral facet or the lateral aspect of the trochlea by bone grafting underneath. And so there are a lot of different ways of doing the trochleoplasty. Our indication is if the patient had trochleoplasty on one side, then I would do a primary trochleoplasty on the other side. But in my practice, most common indication for trochleoplasty is during revision surgeries. The patient has failed a few surgeries, has a type D trochlear dysplasia, and has recurrent instability, then I would do a trochleoplasty for those patients. Just having trochlear dysplasia is not an indication of doing trochleoplasty, as seen in this study by Taiji. 34 patients who were treated with MPFL reconstruction with varying degrees of trochlear dysplasia, And the MPFL reconstruction provided excellent results in spite of having trochlear dysplasia. How about distalization of the tubercle for patella alta? The theory is that if you have patella alta, the patella would not engage in the trochlea, leaving it exposed to instability. So if the patient has a significant patella alta, then how do you lower the patellar height? And one of the ways of lowering patellar height is to move the tibial tubercle distally. Because alta is an established risk factor, tibial tubercle distalization is a commonly done procedure to decrease the patellar height. We did a study where we looked at patellar height before and after MPFL reconstruction. Now, if you look at this study, you can see that in a normal patient, the vector of MPFL is medial and inferior. The MPFL is not straight transverse. It goes inferior as it goes distal by about 15.9 degrees. And what that means is that the more patella alta you have, the more the vector of the MPFL is going to be. And if you do an MPFL reconstruction, then it would bring the patella down. And higher the patella, bigger is the angle. And when we did this study, we looked at the preoperative and postoperative radiographs. And these patients, none of them had any distalization. They were all isolated MPFL reconstruction. And the patellar height decreased after MPFL reconstruction in all patients. And that may be one of the mechanisms of stabilization of the patella after MPFL reconstruction, besides providing a medial tether. It could be that it would also eliminate the patella alta, or at least decrease some of the patellar height. We often see patients with miserable malalignment, which is a combination of femoral anteversion and external tibial torsion. So if you see a patient whose patella is facing in and the foot is facing out when they are walking, that is by definition a rotational malalignment issue, and you need to investigate further. A lot of these patients present with pain, not necessarily with instability, but we have seen them present with instability as well. I've also seen patients who would present with medial instability because the patella is going so far in, they think that it would dislocate medially, but that's actually a feeling and not a true instability. If you do have to correct it, we would recommend correcting femur and the tibia at the same time. And the goal of doing a rotational correction is to restore the femoral anteversion to about 13 to 15 degrees by doing an osteotomy. Lately, in the last year, in the last, I think, 4 cases, we have transitioned to using a nail instead of a blade plate like seen here. And one of the advantages of nailing is immediate weight bearing because it's a load sharing device. So with a blade plate and a subtroch level osteotomy, we do have to wait a little bit till we see some initial bone healing. But with the nail, we don't have to wait. They can be weight bearing immediately. This is an example of patient who had bilateral treatment of femoral anteversion, and then distally we do a supramalleolar osteotomy. And if the rotation that is required is 30 degrees or less, then there is no need for a fibular osteotomy. So we put a plate on the tibia and fix the osteotomy like this. Now let's just talk about the important topic of MPFL reconstruction. So this is how I do my MPFL reconstruction. I use a single tunnel in the patella. I use a gracilis autograft or allograft. And I use the fluoroscopy to localize my femoral attachment point. We put the graft through the femoral tunnel, and it's a pull-through technique. So I'll pull the sutures from the lateral side and then fix the graft with an interference screw. So it's a free graft, and you can call this a double bundle because it does come back and has 2 bundles to it. The more important thing is who needs an MPFL reconstruction. We talk about the indications, those who require treatment of the osteochondral fracture, then we would do an MPFL reconstruction. And here is an example. This patient has a fracture of the lateral femoral condyle, and you can see the 2 headless screws that are used to fix it. There are other ways of fixing it, including sutures, bioabsorbable implants. And you can see an MPFL reconstruction guide pin for this patient. If the patient has an osteochondral fracture from the patella, I usually do it in 2 stages. I tell the family you have 2 problems. You have a fracture of the patella and you have a dislocation of the patella, and it would take 2 surgeries. So in the first surgery, I go and fix the osteochondral fracture, and 3 months later, I go in, remove my hardware from the patella and confirm that everything is well healed, and then do an MPFL reconstruction at that stage. Now, for a first-time dislocation, you can also predict the risk of recurrent dislocation. And when we looked at the risk factors, we found the skeletal immaturity, contralateral dislocation, trochlear dysplasia, and a patellar height more than 1.45. If you had all these 4 risk factors, your chances of the patella going out is more than 85%. And so if we know that it's such a high number based on these risk factors, then it would make sense to stabilize the patella even after a first dislocation without a fracture. Before we do talk about the technique, it's important to look at the common complications of surgery and how we can avoid it. So stiffness, recurrent instability, and patellar fracture are the common complications. Stiffness, we now allow the patients to mobilize very soon. Therapy starts in 2 or 3 days. A lot of time, the stiffness is because of a malpositioned tunnel, especially the femoral tunnel. And so that is, you have to take that into account, and you've got to make sure that you check the tunnel positioning on fluoroscopy. Recurrent instability can happen when the graft stretches out, if there is recurrent trauma, or again, if there are significant anatomic risk factors, or if the tunnel position is not appropriate. And patellar fracture is a technical issue. If you use bigger grafts, if you drill across the patella, then the risk increases. When we looked at our complications, we noticed that 50% of the complications were technical errors and avoidable. But we were looking at our initial cohort when I started practice in 2008. I was just looking at the first 3 years of practice. And then we have improved quite a bit. Now our failure rate is much lesser. I have not had a patellar fracture in the last, I would say, 5 years, in spite of drilling in the patella. And we also found the malpositioned tunnel. The most common malposition was anterior positioning of the tunnel, because back when we started, we did not use fluoroscopy. We used to open it, and we used to look at the landmarks, including the MCL, which is not a very good landmark to follow. Shital's point is the one that a lot of people would know about, and though it was a poorly done study because it was just 7 or 8 cadaver knees, so not a big number. Even then, this is one of the most frequently quoted paper when it comes to femoral tunnel positioning. We reported 5 cases of patellar fracture. Initially, we used to drill 2 tunnels, which are oblique and 4.5 millimeters in diameter. Now we drill a single tunnel, 3.5 millimeter tunnel, and we use gracilis and not semitendinosus. And then we should not cross the patella and drill across the midline. The alternative, so say, for example, you don't want to do a patellar tunnel because you think that there is a risk of a fracture. What are the alternatives? Well, you can do an MPFL, where you can put the graft around the quadriceps tendon just above, superior to the patella. You can loop the graft underneath the periosteum on the anterior aspect of the patella. There are 3 layers. It's very robust. So you can create kind of a tunnel between the bone and the periosteum, and then put your graft and loop it underneath the periosteum. A lot of my colleagues use suture anchors, and you can also use suture, or you can do quartz turn down instead of a free graft. When you do quartz turn down, the attachment remains intact on the patella, so it saves you fixation, and as well as any issues with hardware. There is no clinical difference when you compare different fixation techniques on the patella. So the study looked at suture anchor versus bone tunnel versus all sutures, and there were no clinically significant differences. Similarly, there are no differences in the revision rate based on the graft source, whether you use an allograft or an autograft. It has not shown to have significant differences. However, a double limb graft has a little bit less failure rate than a single limb graft. And what is a single limb graft is if you take a strip of quad tendon and just rotate it, it's a single limb graft. Similarly, if you take a piece of or if you take a part of the patellar tendon and rotate it, that is also considered a single limb graft. One also has to be mindful of the relationship between the MPFL and the distal femoral physis. The MPFL inserts distal to the distal femoral physis. So when you're drilling for an MPFL reconstruction, make sure that it's done under fluoroscopy. And this is a systematic review which showed that the MPFL originated distal to the distal femoral physis in majority of the patient with a mean distance of 7 millimeters from the physis. This is how I do the pull-through technique. So I drill, but I check it under fluoro to make sure that I'm not near the physis. And then I would just put my sutures, pull the bead pin out, and then pull the graft in the femoral tunnel. There have been studies showing growth arrest with open physis. So one has to be careful. Here's an example where the posterior aspect of the distal femoral physis was injured, and the patient ended up with a flexion deformity, which required an extension osteotomy. Another example of having a growth disturbance is a valgus deformity, which is not common. But what happened, as you can see in the middle figure, is that when we were drilling with the MPFL, it actually hit the lateral aspect of the physis. And this was a case report from LA. And the patient underwent an osteotomy. And we all know that we should not do a tibial tubercle osteotomy in someone who is skeletally mature. If they are skeletally mature and they have open proximal tibial physis, then you cannot do a tibial tubercle osteotomy, even if they don't have much growth remaining. So it's not always about having a deformity, but if you have a layer of cartilage in your bone plug, you might end up having a fracture if you're trying to move it and doing a tibial tubercle osteotomy. So the other option of doing a change in the distal vector is doing a Roux-Goldfeld procedure, where you take the lateral half of the patellar tendon, you put it underneath the medial half, and then you sew it to the periosteum. We do this very commonly in patients, in younger patients who are in their first decade. Our technique of MPFL reconstruction with guided growth. And guided growth is something which those who are doing pediatrics would know, because we use it for deformity correction all the time, whether we use a transphysis screw or whether we use a tension bend plate, or in the past, Blount staples were used. And all those things would help to correct the valgus. And we have a bigger series coming out, more than 30 patients who had concomitant MPFL reconstruction and a guided growth procedure to correct their genu valgum. Because if you remember, genu valgum is a risk factor. So if you can correct it by doing a very small operation when the patient has growth remaining, then that would help long-term. So here's a 1-year follow-up on a patient whose initial x-rays you can see had significant valgus, had instability, and then we put a transphysis screw. You can see that the coronal plane alignment is restored. So in short, we do no isolated lateral release, we do no MPFL repair, not a primary trochleoplasty, and we don't do tibial tubercle distalization. The contraindications for doing an MPFL reconstruction is patellofemoral pain, arthrosis, or significant other deformities, in which case we need to correct the deformity first and then address the patella. Let's look at the second group. How do we treat those? So in patients who have dislocatable patella or a dislocated patella, the pathoanatomy is different. If we look at what has happened while they were growing, is that everything has shifted, in a lateral and posterior direction. The quadriceps mechanism is shortened. So in these patients, typically you would have a little bit of a flexion deformity, some external rotation, some valgus, and very frequently a gait issue. And when we look at how does a dysplasia of the trochlea happen, then one theory is that it's because there is not enough pressure of the patella onto the trochlea, so it doesn't remodel. And that is seen when you have early patellar instability episodes. The studies have also shown that the trochlear shape is determined at birth by genetics, but we have seen in other studies that the trochlear shape can change. And one of the change happen because there's a close relationship between the anterior distal femoral physis and the trochlea. So it may be contributing to a normal or abnormal growth because the physis is right there. The other thing is close relationship between the secondary physis, which is the ossification front, and that can also contribute to dysplasia. And studies have shown that if you reposition the patella in the trochlea before the age of 10 to 11 years, then remodeling can happen and the trochlea can get deep on its own. In short, when we see a patient, a young patient with instability, the ideal treatment is surgery so that it can help with trochlear remodeling and long-term results rather than waiting till the patient is skeletally mature because of a fear of a growth arrest. We published our technique of how we do our quadriceps plasty for fixed and habitual dislocation. And there are several other techniques described. It's 3-in-1 and 4-in-1. And basically, you're trying to approach the patella from all the sides. You try and do it to the quad, to patellar tendon, and MPFL and lateral release. So all 4 sides would have surgery. Now, the reason that quadriceps plasty is important and you need to know when to use it is to follow some patients. Here is a patient, 14-year-old with Down syndrome. He already had several surgeries at an outside hospital for patellar instability. And this is a list of surgeries. He had already had 3 revisions. He had tibial tubercle osteotomy, lateral release, and the patient still has instability. And why does that happen? That happens because it's not, the MPFL is not the problem. The tibial tubercle lateralization is not an issue. The issue here in this patient is a quadriceps that's shortened and it's malrotated. Look at the X-ray of this patient after 4 surgeries and tibial tubercle osteotomy. Look at the patellofemoral joint, see how much destruction there is on the trochlea, and the patient still has symptoms. So what do you do for these patients then? In short, MPFL reconstruction and tibial tubercle osteotomy is not the answer to all instability. If they have habitual dislocation, if they have lock dislocation, fixed dislocation, or a permanent dislocation, in these cases, they would need a quadriceps plasty and not an MPFL reconstruction. Our 4-in-1 quadriceps plasty involves wide lateral releases and install 2 quadriceps realignment, a Roux-Goldschmidt procedure, and quadriceps lengthening. The lateral release, if you just do a lateral release and you relocate the patella, then you'll be left with a big void. You can sometimes get the skin stuck to that area, which can kind of tether the skin a bit, and you can get some swelling at times. So we prefer to do a lateral lengthening and not a lateral release. And how the lengthening is done is through the 2 layers that make up the lateral retinaculum. The superficial oblique retinacular layer and the deeper transverse capsular layer, and you go between those 2 layers, make these cuts, and then when you suture them back, it's actually a Z lengthening of the lateral retinaculum. And this is the technique paper that we wrote in 2021. All these technique papers are open access on the journal. The journal is Arthroscopy Techniques, so all videos are open access, so it's easy for you to see it. We have several videos. We have one with the lateral retinacular Z landing. We have a quadriceps plasty video. We have a video of MPFL reconstruction with guided growth on that platform. So in short, the way we do a 4-in-1 quadriceps plasty, we make medial and lateral parapatellar arthrotomy and we mobilize flaps on both sides. Then we take the lateral, the medial flap and suture it to the lateral aspect of the patella. So if you see it in an axial view, then we'll take the medial flap and suture it to the lateral side, and that would maintain the patella in the groove. Along with this, we would do a Roux-Goldschmidt procedure, and then final step is to do a quadriceps lengthening in a stepwise or a sequential setting. Here is a video of doing the quadriceps plasty. It's a midline incision. The knee is flexed over a triangle. This is a part of the lateral release. So you just don't go all the way into the joint with this cut. You try to be between the layer 2 and 3 on this lateral side. On the medial side, you can just do a clean arthrotomy, and then you can remove all the adhesions between the patella and the distal femur. At this time, I'll also slide a cob on the anterior aspect of the femur to remove any adhesions between the quad tendon and the bone. Then we'll mobilize the medial flap. This medial flap contains the VMO, the medial retinaculum, and the MPFL. And then we'll mobilize this and we'll take a tentative suture from the medial side and we fix it to the lateral border of the patella. So the medial flap goes all over the patella and then is sutured to the lateral side. That's why it's called a tube quadriceps plasty, because the patella is now in a tube. And then once we have this tentative suture, we kind of range the motion and evaluate the stability. Then we would do the Rugoldswit procedure, where we split the patellar tendon in its midline, and then we detach it from its lateral insertion, lateral half. And you have to be careful that you don't want to peel too much periosteum or go into the cartilage, otherwise you can get some growth disturbances. We bring it underneath the medial intact half of the patellar tendon, and then we suture it to the periosteum. You can use an anchor here if you want. We just suture to the periosteum, and then we cast this patient for 3 or 4 weeks after surgery. So we don't need any implants for this. We don't also need any fluoro. We don't need any equipment, no drilling. This is soft tissue rebalancing surgery, the quadriceps plasty, and then you reinforce the quad tendon all the way from the patella to its proximal aspect, and you just suture it. And that would give a very nice tracking to the patella. But at this time, if you notice that the patella, yes, it's tracking, but as soon as I touch it or push it a little bit, it dislocates, and this is where I would add the MPFL reconstruction. And then you attach the quadriceps mechanism. You do the lengthening part where the vastus lateralis is sutured to the quadriceps tendon in a much more proximal position than where it was already attached. And then we put a cast on, and this stays on for about 3 or 4 weeks. The time to go back with full activities is between 6 and 9 months, and they would need physical therapy after the cast is taken off. When we looked at the results, we had good results at 2 years. So we had 3 failures out of 17, and all 3 of them were in patients who had habitual dislocation and extension. So I think in this group, habitual dislocation extension, a distalization would make more sense. Okay, so in summary, we looked at different patterns of instability. We looked at the procedure of choice for episodic dislocation, which was MPFL reconstruction. We looked at the technical details, how to avoid the physis, how to avoid femoral tunnel malposition, and to avoid patellar fractures. We looked at quadriceps plasty, which is a procedure of choice for the more complex patterns of habitual and permanent dislocations in children. And I thank you for your time, and happy to take any questions.
Thank you, Shital. Shital, you can stop sharing. Yeah. Shital, thank you for this very comprehensive presentation. It changed the understanding of patellofemoral instability, because most of us were stuck with MPFL and typical osteotomy.
Yes, but that is typically not the answer. When it comes to more complex patterns where you see a jumping J sign or habitual dislocation and extension, those would not work. I've had my shares of failure. You got to distalize these patients if you have habitual dislocation and extension. And if they are younger patients, then I use the Rugoldswit to distalize their patella. And there just needs to be one person, I think, in a region who would do trochleoplasty. Everyone doesn't have to do it, because it's a little bit more involved procedure, and it requires a little bit more training. So not everyone should be doing it, because I've seen failures and complications from trochleoplasty. So that's also not the answer. I think you can refer it to someone who does it more frequently. I think that's the best way to treat these patients.
Thank you, Shital. Shital, I just want to know the difference between a CD and an MR with respect to the TTTG distance. So I've been following David DeJours and the Lyon School's work. And is there a difference? Because TTTG on a CD is 20 is the cutoff, and an MR it's 30, is it?
Yes. So yeah. So you're absolutely right. So we use MRI for a few reasons. One is that the CT involves radiation, and then our kids are sensitive, especially the physis and the cartilage and everything. So we are not very keen on getting a CT scan. The other thing is that the MRI gives us much more information because you can look at the MPFL, you can look at the cartilage surfaces. So even besides TTTG, we can get a lot more information. We can also look at the sagittal MRI and look at the patellofemoral engagement. When you have patella alto on an X-ray, doesn't always mean that you need to distalize. You need to look at the overlap on a sagittal view between the patellar cartilage and the trochlear cartilage. And if that overlap is less than 20%, then you can distalize. So that has been described by the French, actually, and that's the patellofemoral index or the patellotrochlear engagement. So MRI gives us a lot more information because you can, calculate everything from the cartilage surfaces, avoids, irradiation. The only advantage that it's quick, like time-wise. So if it's a young patient, probably, 8 or 9-year-old, you might have to sedate the patient if you want to get an MRI versus CT is just like an X-ray. It's pretty quick. But there are differences in values. The cutoff values for TTTG are more on the MRI compared to the CT scan. But TTTG is a fixed number, right? 20 millimeters, and everyone's knee is different size. So how can you use a fixed number on the different size knees? That is an issue because if you look at our population, younger patients, and we have looked, and it has been published that the TTTG, normal TTTG ratios are much less in children because they have smaller knees. And so the cutoff value, if we use a 20 millimeter cutoff value in children, I would never have to do anything because no one is ever going to reach there. 20 millimeters is sometimes going to be out of their tibia. So in kids, the normative value is much less. We routinely do the Roux-Goldthwait procedure because we see that once we align the patella, they have a lateral vector. The TTTG may be normal. So TTTG is used as a guideline, but it cannot be used to make all surgical decisions. It just kind of helps you to figure out where you are.
Thank you, Shital, for that. And Shital, recently I hosted a few surgeons, like 2 different procedures. One is a dynamic MPFL, where you're detaching the gracilis from the insertion and getting the patella. Advantage is you're working only on one fixation point. And the other one is, like you mentioned, the quads takedown. You take down the medial half of the quads and bring it to the Shital's point. So in a pediatric patient, do you think these procedures are good? Because one is the fixation point and both are dynamic procedures.
So it's a good question. So from a patient safety standpoint, it does make sense to avoid drilling near the physis or drilling in a small patella. However, for some time, I only used to do soft tissue fixations for MPFL. I would loop it underneath the periosteum on the patellar side and loop it around the retinaculum on the femur side. And a lot of patients did well. But when you check these patients post-op, the apprehension and the laxity is a little bit more compared to patients who have 2 bony fixation, one on each side, on the patella and the femoral side. So we went back to bony fixation on both sides. So you're right that in principle, it can avoid growth disturbances, but how common is it? Like we looked at more than 500 MPFL reconstructions, not a single patient with growth arrest. And the reason is that, so as I said, we had patellar fractures when we were drilling big tunnels, but now we have restricted it to 3.5 tunnels. And in last 300 patients, we have not had a single patellar fracture and not a single growth arrest because you need to use fluoro. And you need to use fluoro throughout, like not just at the starting point, but when you're drilling, you need to check it, make sure you don't hit because your distal femur physis is undulating. It's not a straight physis. So you just can't assume that you're going to get the point correct and then you just shoot the K-wire across or your guide pin across. You need to check it as you're drilling to make sure you don't touch the physis. And we have not had issues. So I don't prefer to use the soft tissue fixation, but for example, MQTFL is looping around the quadriceps tendon, and in the surgeon's hand, those who have described it, the results are pretty good. I've had a little bit bad experience with that, and I don't use it. But same with the quad tendon. In my fellowship, we only used quad tendon. This was back in 2003 when I was doing my fellowship with Dr. Noes. We only used quad tendon. The problem that I found with quad tendon sometimes was the length, that I would not get enough length to put it in the bone. And the second thing is that the rehab, I found it difficult that compared to the hamstring tendons, that if you have an extensor mechanism problem and you're harvesting an extensor mechanism graft, you're just going to weaken it a little bit more. And I had patients who had a lot of extensor lag. Now, at 6 months, they did not have a lag, but initial rehab was more difficult for the quad tendon patients. So I use hamstring graft, exclusively hamstring tendon graft and free graft.
Thank you, Shital. Shital, just one last question before we end up the session. Now, Shital, you have given a very, very important message about using the Rugoldt weight as for the lateralization part on the tibial tuberosity, right? So at what is the cutoff, what is a cutoff beyond which you can do a tibial tubercle osteotomy? Say what age? Is it 16?
No, not 16. Typically in boys, 13 and a half, in girls around 12 and a half, after which the tibial tubercle apophysis is fused to the main tibia. So when you look at the lateral x-ray, if the apophysis is fused, then you can do a tibial tubercle osteotomy. So it's not 16, it's somewhere, depending on the skeletal age of the patient, it's usually 13 and a half. Now a patient with who is 12 years may have a bone age of 13 and a half. And a patient with 16 may have a 12-year bone age. So you got to look at the bone age and not their chronologic age. But if the bone age matches the chronologic age, then typically 13 and a half in boys, and the apophysis starts to fuse. So after 14, it should be safe to do it. But if you have a gap, when you're looking at the lateral x-ray, it's not completely fused, then you should not harvest, not just because of the fear of recurvatum, but because in your shingle, in your tibial tubercle shingle, you would have a cartilaginous line. And then that's a weak point, you can fracture through it. Or when you're fixing it, it can break.
Thank you, Shital. Shital, I think that's all the questions that we have for this session. Thank you for this wonderful, comprehensive talk, and really look forward for more in future.
Thank you very much. Thanks, Hitesh.